Welcome back to Resilient Pathways. I'm Chris Fagundes. My guest today is Dr. Samantha Henry, a clinical neuropsychologist and assistant professor of neurology at Baylor College of Medicine. Her clinical work spans neurodegenerative conditions, chronic illness, transplant evaluations, and extends into the operating room where she maps language during brain tumor surgery. Much of our practice involves patients whose language, schooling, and cultural background do not match the samples of which most cognitive tests were normed. So, thank you for being here, Samantha.
Thank you, Chris. I'm very excited to talk about my work and the patients that I see. So I'm looking forward to this spirited discussion.
Yeah. So for someone who's never heard of the job title, what is a clinical neuropsychologist and what does their evaluation add that a neurological exam, imaging, or laboratory test cannot?
It's a really great question, and it's one that I'm often explaining to patients, usually the first time that they're meeting me, because oftentimes they've been referred and they're not really sure why or what I do. And they're also expecting the visit or evaluation to look similar to, when they go see their regular physician. So a neuropsychologist essentially is a provider who specializes in cognitive or brain health. And so my goal or my area of focus is looking at different domains of cognitive functioning like memory, attention, processing speed, language functioning, executive skills, and trying to get an overall sense of this person's cognitive strengths and weaknesses. And the goal often depends on the patient population that you work with and the nature of the referral question. But for me, for example, I work with a lot of older adults, and so the question is usually, does this person have a neurocognitive disorder, and is that something that might be progressive? So in a sense, does this person have a form of dementia?
Mm-hmm.
And so this is very different from neurology, although we have related disciplines and it's a shared goal. So a neurologist is coming at this more from the physical side. So they're doing their physical and neurological examination, looking for any signs or symptoms that might indicate any sort of neurological disease that might be going on. So we've all had some sort of brief neuro exam. Sometimes when you go to your primary care doctor, that's not necessarily as detailed as if you're going to see a neurologist. But the neurologist often refers to a neuropsychologist when the question comes up is there a cognitive disorder at play here that might also be happening in tandem with these other neurological physical symptoms? So the neurologist is a frequent referral source, but they are the ones that can order neuroimaging and can prescribe medications. So they would refer to me, use my report to look at my clinical findings and diagnostic impressions, and then use that to formulate their case or their summary of what's going on with that particular patient's case.
Okay, interesting. So when you say cognitive disorders in older adulthood, people typically think of Alzheimer's. What other cognitive disorders are you assessing, and how do you know the difference?
So usually Alzheimer's disease is the one that comes to mind. It's the one most of my patients are concerned about because it is the most common form of dementia. But Alzheimer's disease is just one form. There are many other types of dementias and neurodegenerative conditions. Some of them include Parkinson's disease. And of course, someone with Parkinson's disease can go on to develop Parkinson's disease dementia. There's vascular dementia. There are atypical dementias and movement disorders that we also look for. So, for example, progressive supranuclear palsy, multiple systems atrophy, and then more rare conditions like corticobasal syndrome. And then we also have these rare forms of dementia that, have become more present in pop culture simply because there are famous people or celebrities who've been diagnosed with them. So, for example, primary progressive aphasia, when we're thinking about Bruce Willis, for example. So those are many of the conditions that we're looking for. But I will say Alzheimer's disease is my bread and butter. Now, I might be seeing someone who's not necessarily concerned about having a neurodegenerative dementia like Alzheimer's disease. They might be coming to see me because they've had some sort of acquired brain injury, like a traumatic brain injury or concussion. They might be seeing me because they are concerned that they have maybe some long-standing neurodevelopmental condition that was never diagnosed, for example, ADHD. Or if I were to work in pediatric populations, those referring questions might look very different.
Got it.
Other things that I, in particular, am concerned with is, what are the cognitive effects of a chronic illness like lupus or, multiple sclerosis?
Mm-hmm. Interesting, interesting. Now, our audience is sort of broad in its demographics, but a part of our audience are actually, college students and young professionals trying to figure out, what they're doing, what they want to do for a career. So, for someone considering, this career, what does the training look like, and how did you become interested in it?
I love answering this question because it's not straightforward, but I'll try to just give you the highlights. So for me, and I think for a lot of people, and we don't really talk about this a lot, it wasn't a sort of, I knew automatically this is what I wanted to do. In fact, my journey to becoming a neuropsychologist was one where I really didn't know what I was getting into until I was already in graduate school. Now, I had a lot of help along the way, which I'm very grateful for, people steering me into this profession without me realizing they were doing so. But I went into college majoring in chemistry, and I really wanted to be a forensic scientist. I was so convinced that I wanted to be like the actors that I saw on CSI and Law and Order, and then I realized that I didn't really love chemistry, and I didn't have the passion for it that my classmates did, but I knew that I still wanted to do something in that realm. And I realized, I really identify with B.D. Wong from Law & Order SVU. He was a forensic psychiatrist, and that really was what motivated me to look more into psychology. And then one day I walked into the student office and changed my major, which was a huge deal at the time. For me, it was probably one of the biggest things I did.
Sure. Big identity change.
Yes, and I wasn't sure how that was going to work out for me. But, 2 years later, graduating with my degree in psychology, and I decided to pursue research. So I worked as a clinical research assistant for 3 years, and that was really what helped me get the experience that I needed to better understand that this was the career I wanted to go into. So I was doing a lot of neuropsychological testing without knowing that that's what I was doing, in addition to all the other things that a research assistant might be doing, collecting blood samples, things like that. And I really loved working with the patients and the caregivers. And as I was applying to graduate school, I was thinking that I wanted to go into geropsychology, which is, the study of working with older adults. And, an older college advisor spoke with me and said, it sounds like you're really interested in neuropsychology. You keep coming back to this assessment portion of it. And I was like, I don't know what that is, but sure, it sounds great. And my boss had also been talking to me about that. It sounds like you're really interested in neuropsychology. And lo and behold, I was fortunate enough to get admitted into a program for that, and the rest is history.
Interesting.
Now, if you're interested in becoming a neuropsychologist yourself, it does require a lot of dedication. And so obviously you want to get your bachelor's degree, and a psychology degree or related discipline is great. It's not required, but it will certainly make your life easier and make the application process easier. And then some people want to go immediately from college into graduate school. Others might take some time off like I did. And I think either path is worthwhile. And there are specific guidelines for education and training in neuropsychology, and no two paths look exactly the same. So generally, you want to get into graduate school, which that is a whole discussion in itself. It's even more competitive and rigorous than it was when I was applying, and back then it was also considered to be quite competitive. And then once you're in graduate school, you can expect to spend maybe about 4 to 5 years doing academic work and clinical work, getting that experience that you need. And then you go through internship, which is similar to a medical residency, but it's a year long, and that goes through a very similar match process like it does for medical trainees. And then what is now come to be the expected sort of gold standard approach is a 2-year fellowship. So after you get your degree, it's a postdoctoral fellowship where you're learning to be an independent practitioner and preparing for being on your own one day. And so that is the traditional, probably most common path for people to become neuropsychologists.
Okay, interesting. And so as a physician that, let's say, becomes a neurologist, they, first go through medical school in the same way that the pediatrician will go to medical school, in the sense of the classes they take and entry, their cohort. When it comes to clinical neuropsychology, are you in a class full of people that are becoming clinical neuropsychologists, or is it broader than that, where it would be, for example, a cohort of people that want to be different types of clinical psychologists, and some of that cohort is aspiring toward clinical neuropsychology? How does that work for our, younger people that might be kind of looking into these programs?
And that's an important point that you've raised, Chris. It is very much as you've described it. So first and foremost, clinical neuropsychologists are clinical psychologists above all. So we go to school and we do our training with that in mind. And then, of course, we specialize in neuropsychology. Now, for those who are aspiring neuropsychologists, you may be faced with, do I want to go to a PhD program or a PsyD program? Do I want to go to this program that says that they give degrees in neuropsychology versus one that says I'll get my doctorate in clinical psychology? And, I want to emphasize that your clinical psychology skills are going to come in extremely handy as a neuropsychologist. Just because you may not be doing therapy in the traditional sense doesn't mean that those clinical skills are not still valuable and worthwhile. So for me, for example, which is probably the case for many practicing neuropsychologists now, we went to school to be clinical psychologists. We specialized in clinical neuropsychology, and our classes were filled with peers who were interested in different specialties. So, for example, those who knew that they wanted to be clinical psychologists and wanted to work in psychotherapy, delivering evidence-based therapies. There were individuals who knew that they wanted to work in health psychology. And then, of course, there were those of us who wanted to do clinical neuropsychology. And some of my classes even included people outside clinical psychology, specifically like behavioral neuroscience, for example, or those who wanted to be developmental psychologists, which I think has a lot of value for integrating different perspectives during certain academic subjects like developmental psychology or, aging. All of that, I think, can be really helpful towards broadening your perspective, even if I just want to focus on this one thing.
That makes a lot of sense. That's really helpful. So let's pivot a little bit into the clinic now. So someone shows up in your clinic on a Tuesday morning. Can you maybe walk us through the day? This institute is a lifespan institute, but we're, focused on aging, one of our kind of specific interests. And I get the sense that most of the patients that walk through your clinic are going to be older adults. Is that correct?
That's correct.
Okay.
Yeah.
So what would that look like when they come in? I know no experience is the same, and it might be a first visit versus not. But can you just walk me through what a typical day would look like?
Sure. So usually I'm seeing someone for the first time, although I do have repeat evaluations that are done. But usually the person presents, and I'm the first person that they interact with. So I am going over their background and history, for example, their medical history, current concerns, do they have any cognitive complaints? And ideally, they've brought a loved one or, someone who can act as an informant or collateral to either provide supporting information or to provide a different perspective. And then, after we cover those basics, then I want to know more about their education and occupational backgrounds, because that provides a lot of important information about where their premorbid functioning might be or their baseline level of abilities are, and helps me frame my evaluation better. And then we talk about what they can expect from the evaluation, because for so many people, they have no exposure to neuropsychological assessment. They might not have been really given any sort of guide for what to expect, and I want to set the tone. So then the next part of the evaluation, usually about 2 to 3 hours of testing. And in my clinic, we rely a lot on paper and pencil testing, although I know some other neuropsychologists are incorporating more technology. So there might be some computer-assisted testing that takes place. But for us, and especially because of the population we work with, we do a lot of paper and pencil tests looking at different aspects of memory, so both verbal and visual. We look at language and communication. So, for example, verbal fluency. We're looking at aspects of attention and processing speed, or how quickly someone can formulate responses or provide information. And then executive functioning is a big one. So looking at their problem-solving abilities, judgment, their ability to multitask or think flexibly, and then we look at visuospatial abilities as well. Those are the main ones, but of course there are other tests that, depending on the patient or family concerns or the referring question, we might incorporate as well, like aspects of social cognition. So all of that takes place. They might be tested by me or, a neuropsychologist, or they might be tested by a psychometrist, which is another profession that for those interested might want to know about. A psychometrist is someone who is a trained professional and they know how to administer and score the neuropsychological assessments that we give. They are an adjunct to the service that we provide. They don't interpret or diagnose, but they're integral to the work that they do, and they make it possible for me to be in multiple places at once. And so after that, I usually meet with the patient again to, schedule a follow-up, make sure that there is continuity of care there. My hope is that they come back to me for feedback of their results so we can discuss what we found, what our clinical findings indicate for them, and then any recommendations that I have for them, and perhaps a roadmap for how to proceed from there.
Okay, interesting. So would at times a neurologist that might suspect something send them to you for a referral, and you also send this information back to the neurologist, or is that really not the kind of the workflow when we're talking about someone that is, trying to understand if they have having cognitive decline?
Most of my patients get referred to me from a physician, and because I work in the Department of Neurology, it is often a neurologist, but not always the case. And when I'm formulating my report, I am thinking about who my stakeholders are. So it's not just the patient and family, but also the referring physician, if that's a neurologist, or if it's a transplant physician, or a neurosurgeon. I'm making sure that my report is intended for both audiences, which is not always the easiest task, but I hope I'm doing a good job of that. My feedback, though, that is with the patient and family. And that's where, regardless of how my report is formulated, I'm trying to synthesize the information, put it in layman's terms, and then give them things that are meaningful and that they can take actionable steps on.
Okay, that makes a lot of sense. Now, someone arrives to your clinic for a test and they're exhausted. Maybe they didn't sleep well the night before. I think we all have had those experiences where you don't get a good night's sleep. We even notice where we might be driving a little different. Just, have to focus a little different than we do if we're well rested. Or maybe they walk into the clinic and you can see they have really high level of anxiety. How does that influence how you're testing and how you interpret the results?
This happens a lot more than you think. And one of the things that I think is important to note is that each clinician might handle that differently. And it might also depend on patient-specific factors. So, for example, I would still tend to do my interview to gather more information. I want to know, you're exhausted, you didn't get a good night's sleep. Is that typical for you, though? And for many patients, it is. They have chronic sleep disturbances. And so this is actually going to be helpful for me because now I know this is how they're used to functioning. And my evaluation will proceed because it's still an accurate reflection of their abilities. And the same thing with anxiety. Most of us get anxious when we're going to a doctor's appointment, and especially when you add on an extra layer of test anxiety or not knowing what to expect. Unfortunately, for some of my patients, regardless of any materials that we send out in advance, they might not realize that they're going to be with me for, let's say 3 to 4 hours, or that they're expected to do all of these tests. And, automatically people think I didn't study, which I just want to clarify. These are not tests that you can study for, but that heightens the anxiety. And then you add on to the fact that someone might have a generalized anxiety disorder. So all of those components are things that I want to document, both, in my assessment of their mood from talking with them during the clinical interview, but also anything that might be in their medical record if they do have a prior diagnosis. So in those cases, testing, again, can still be worthwhile because if we suspect based on the pattern of findings that we're seeing or even just behavioral observations that, this person was really anxious when we started this task, but as their comfort level increased, I noticed that they were better able to focus their skills or their strategies to do better on tasks that might appear to be harder at face value. So all of those are important things to take into consideration. And oftentimes I find that, we can pretty reliably distinguish between, is this, something that is a temporary state for the person versus is this an indication of a longer standing issue? The other thing with anxiety is that oftentimes mood and anxiety changes might occur before the onset of, notable cognitive changes. And so this at least helps us figure out whether there's something more going on. Should we be concerned about a neurodegenerative process that might be taking place, something incipient, or is this a mood or anxiety disorder that we can manage and that's just separate from any sort of neurological changes?
Now, you've used the word cognitive multiple times here. For listeners that might not have sort of a background in psychology or related field, that could take on a lot of different meanings. What do you mean when you say cognitive?
Yes, so cognitive, I'm referring to aspects of thinking, which can include memory, language and communication, all the other domains that I mentioned, like executive skills. It's not exclusive to those. There are many other aspects of cognition, but those are the main ones that a neuropsychologist is concerned with. So essentially, it's how our thinking skills impact behavior, impact, the ways that we interact with the world, interact with others.
That makes sense. So if we were going to sort of break it down to listeners that were maybe, not familiar with kind of these different domains, we would say somebody's behavior is observable, something different than cognition, but it could be driven, obviously, by the way they're thinking, right? Is the way they behave. And how do emotions fit into that? Because when people think of psychologists, they think of experts in emotions. But what I'm hearing there is that might be a little bit different in the sense of kind of the aspect of how you're thinking about these assessments.
So our cognitive abilities or our thinking abilities don't exist in a vacuum. So when we think about the role of a neuropsychologist, this is where our clinical psychology skills come into play because mood and psychological functioning has such a big impact on our thinking processes and how we engage with different functions and activities, how we move about the world. So, for example, if someone is depressed or anxious, part of their symptomatology might involve changes in cognitive abilities or efficiency. And so those are things that we want to take into account because if someone's severely depressed or severely anxious, that needs to be addressed before we can really do anything else or before we can say that the pattern of findings on testing indicates something more is going on. So, that is one of the main things that we take into account. I always tell patients that I'm a neuropsychologist. So the neuro piece is where I'm asking about all these things related to your brain health, like how far you went in school, what kind of work you did, how you're doing with managing driving, your finances, how you're doing at work versus, the psychological aspect, which that's all part of your brain health too. I want to know, how are you doing with managing stress? Are you, feeling depressed? Are you feeling anxious? Do you have some symptoms that might be uncomfortable to talk about that maybe you've never shared with anyone, like experiencing things or seeing things that other people don't seem to see or hear?
That makes sense. And you mentioned education, and I know there's a growing literature showing all kinds of age-related health disparities when it comes to different neurological disorders, and this is across the gamut to people's health as they age in general. But when we think about actually the testing, how do sort of these kind of contextual factors that kind of interact with people's developmental history, like education history, right? How does that influence the way you are administering the test and also the way you interpret the test? So to give just an example of what I might mean, two people come in worried about cognitive decline. They're referred to you. One has an education level of, let's say, a high school education, right? Another has a medical degree, right? How does that influence, or if at all, how you administer and interpret these tests?
Another great question. Education actually has a really big impact on both test administration and test interpretation. So, for example, if I had an individual who maybe had fewer years of education and was more test naive, I might consider what kinds of tests I would give them. Am I going to give them? I'm thinking specifically of one of the harder working memory tasks we have that involves a lot of rapid mental calculation. Do I want to give that to them? Is that going to be a best gauge of their abilities when that may not be a skill that has been in practice for them or that they even really learned how to do, versus the person who has more years of education who that might be not necessarily second nature, but more of an expected skill for them.
Okay.
And so when we think about education, one of the things that I should mention is that neuropsychologists tend to work with tools or tests that are validated and normed, and they're often stratified by different factors. So, for example, age and years of education. Now, that means that I can more reliably make comparisons among individuals. So when I talk with patients, I tell them, I'm going to compare you to your peers. And so for the individual who has, high school level of education, that means I'm comparing them with other people who have about a high school level of education. And for the person who has a medical degree, for example, someone who has about that same level of education as well. And then on top of that, there are other things that we need to take into consideration. Unfortunately, our history here in the United States is that everyone does not necessarily have equal access to education in the same way. So two individuals can have the exact same years of education. They both graduated high school, but that in practice can look very different in terms of quality of education. We've all heard of situations where people were sort of passed through school and things like learning disorders were never identified or addressed. And this tends to happen with my older folks more so than the younger folks because of different policy changes and things like that. But I have to take that into consideration. I also have to take into consideration our history of segregation. And there are experts in this area. I'll mention a couple. So Dr. Manley, for example, Jennifer Manley at Columbia University, my former research mentor, Dr. Michael Crow at the University of Alabama at Birmingham. They've looked at different factors or proxies for quality of education, like reading ability, or going back into archives and looking at different resources that people had access to, like student-teacher ratio, whether there were textbooks and other resources available for people based on, things related to segregation or, based on different sort of resources available. And they found that that's a better indicator of, capturing education quality than just years alone. And there's much more research on this than I will delve into right now, but that's also something that I'm taking into account in the clinical interview, especially for our individuals who might not be based in the U.S. or who have a less traditional educational experience. I see a lot of individuals who might have been from a family of migrant workers. And so while the rest of their peers attended school from, August or September throughout, their schooling might have been delayed because of the season. So they might not have started school for a couple months, or they had to leave school early to help out with the family work. And then we have individuals who relocated to the U.S. later in life. And so all of their education might have taken place outside of the United States. And so I spend more time gathering information about what their education experience looked like, whether they had any limitations in school that weren't addressed, whether they weren't meeting certain benchmarks. And that all gives me more of a clue of how to frame this. And so just thinking back to a couple cases that I have had times where I've plainly said in my report that I believe this person had, a learning disorder, most likely dyslexia that was never identified when they were younger. And it might be the driver for why they're coming to see me. Someone who's leaving college and they're like, I always struggled and I'm really struggling at work and I don't really know what's going on. And those cases are pretty sad because it's clearly a symptom of someone not being told or not being identified early enough on for this to have been addressed, or they've had to overcome these barriers without knowing why. I had another situation where I had an older gentleman, very accomplished, but when we did the testing, I was struck by just how impaired his reading scores were. And I come to find out that while he was never formally diagnosed with a learning disorder because of, the generation he's from, did recall, I had to spend time after school going to do some extra reading. I didn't really know why. I figured it was because of, these other factors. And it pretty much lined up with he likely had a reading disorder when he was younger, but he overcame all of those.
Got it. So I'm kind of thinking in two directions. You went exactly where I was going next. One direction is with these nuances, I guess they're more than nuances, that would be the wrong word, with these contextual and developmental factors that have a, huge effect on these outcomes. I could see that impacting how you're interpreting the test in the sense of if they're actually showing signs of dementia. Am I correct? And in addition to that, I'm curious how, when I kind of read work in this area, there's work to show that education levels in certain kind of jobs even like buffer or exacerbate disparities in the sense of who exhibits cognitive decline earlier and how severe. So I guess my question is twofold, but I think they kind of dovetail together at some point that we might not even be fully understand as researchers. One is, how do you determine whether someone should be kind of thought about as having dementia or mild cognitive impairment when you know this kind of history? Is it like an adjustment in the scores? Is it clinical intuition? In addition to that, why, or what do we know about why it seems that education level actually predicts, for example, likelihood of dementia in age and onset? What are your kind of thoughts on that?
Okay. So the first part of your question, part of it is clinical intuition and part of it is relying on our validated norms. But of course, as we go to the lower end of the spectrum where people have fewer years of education, we actually don't have a lot of data that is useful for making clinical judgments when it comes for people who, they might have had to leave school early for various reasons. And so that's where clinical intuition becomes more of a relevant factor there. So for example, I have had individuals who they left school maybe after 2 to 4 years of schooling, either because of cultural reasons or socioeconomic reasons, and they might also be from a different background. So maybe their schooling wasn't here in the United States, and so I have to rely on the fact that I don't have norms that will reliably tell me whether this person is operating at the same level of their peers. And this is where my clinical interview becomes in really handy. I want to know what kind of work this person did, and of course, obviously, lower years of education does impact your occupational attainment. But I want to know whether this person was operating independently and able to do things that, we don't give a lot of credit to, but, raising a large family, that requires a lot of executive skills.
Sure.
Being able to manage a full-time position, even with fewer years of education, and, how they operated on a daily basis, and how is their current functioning different from that, if at all.
That makes a lot of sense. And I'm curious your thoughts on the findings that we see broadly about, these crude measures of education, income, and race and ethnicity contributing to the disparities of dementia onset and progression. Do you have any thoughts in that regard? I know it's an active kind of area of research, but I'm just curious as someone that's sort of on the ground floor, kind of their thoughts on those differences that emerge.
Just to make sure I'm understanding, so talking about some of the proxy measures that we're using for gathering information.
Oh, so I guess what I'm getting at with this question, and thanks for kind of pushing me to clarify. On one end, there's the assessment piece, right? Where you're genuinely need to figure out, does this person have, let's say, cognitive decline, a dementia, mild cognitive impairment, taking into account all of these factors and using your clinical judgment. On the other end, unless the data is skewed very poorly, we do have work to show, for example, that we're more likely to get dementia based on not just, genetic risk and contextual factors like stress, social support, but literally these kind of socioeconomic kind of factors and demographic factors like education, income, race, ethnicity. And I'm just curious your thoughts on why do you think there are differences? I understand on the side of assessment, But why, on sort of the outcomes in general, do these disparities exist? And, is there something we can think about as a society to kind of close those gaps?
There's a lot of research about a concept called cognitive reserve, and they've investigated some of these factors. Why do these disparities exist? And a lot of it, and I don't want to make it too simplistic, but a lot of it boils down to access to enriching environments. Okay. So some of the factors you mentioned, like education, that's an early childhood risk factor. Mm-hmm. So cognitive reserve, think about it as being what makes someone resilient to cognitive changes. And so you have a related concept of brain reserve. That's not really something we can do too much about. It's, how many neurons do you have, the density of your nerve cells, and, the thickness of your brain volume. Those are all ways that we get at brain reserve. And so we think about that as more hardware. And a lot of that's determined by genetics and things that we don't really have a lot of control over. But cognitive reserve, that's one where people can be resilient to brain damage and neurological damage, and it's dependent on these more modifiable factors like how far somebody went in school, the quality of their education, any sort of enriching environments they had throughout the lifespan, not just childhood. So whether someone had an occupation that required a lot of complexity, in particular interpersonal complexity, so being able to interact with people, and then other things like learning a second language, whether they continued to engage in lifelong learning after they left school. Those are all factors that help promote resilience, and that, contributes or explains some of the disparities that we're seeing when we talk about things like race and ethnicity. So that's really a poor proxy for this other larger idea of things that promote cognitive reserve.
Yeah, that was exactly what I was trying to kind of grasp, but that makes a ton of sense. So you mentioned interpersonal complexity, and obviously that's one of many factors. But I couldn't help but think, as work has become remote and hybrid to a certain extent, kind of what your thoughts are on, is that going to lead to any kind of differences in kind of how people are able to benefit from the workforce in those soft ways, because quite frankly, they don't have to have those conversations in the same way, right? It's just speculative, and I'm curious how, if you have any thoughts on that, and how important things like kind of being in the workforce or being socially engaged, whether it's whether it's in a club or someone's church group, those type of things, instead of, just this is what I do for work, right? But the interpersonal part, how does that impact people's cognition as they age? Do you have thoughts on that are either kind of from sort of an observational standpoint, or if you know any literature on that?
So I'm not as well versed on that literature as I am on other things, but I will say that we know one of the biggest, things that people can do in terms of promoting their own brain health is being socially engaged. And so this is oftentimes a recommendation that I have for my older adults who are being proactive about their brain health is, make sure that you're spending time with people, trying to find ways to engage outside of just, your family, participate in things where you get to interact with other people. So we know social engagement's really important for brain health. And when we think about things like remote work, which I want to say I think that's a huge benefit in being able to be flexible with our work and our work-life balance. But I do suspect that it might have drawbacks in how we engage with people and how we're actually getting that social engagement at earlier stages. Now, if you recall, I am talking about these lifespan enriching activities and how occupational exposure, especially in terms of interpersonal demands, can be helpful for building cognitive resilience. And so with the kind of situation we find ourselves in now, largely in part to the COVID-19 pandemic, this increased remote work access, I think, has benefits in terms of, lowering stress, which can increase things like allostatic load that has an impact on brain health, but then has the drawback of now we're not interacting with people in the same way. And, this is not a common domain that neuropsychologists assess, but it's not one that we are shying away from either, but the social cognition aspect, which we know is important for disorders like autism spectrum disorders. It's important for ADHD. These are things that we look at, and even for things like Huntington's disease, the social cognition piece. So if people are not developing socially in the same way, because now I'm going back to even thinking in terms of pediatrics, kids who had remote schooling, they're missing that social development piece that we would expect, or so these benchmarks we're expecting to people to achieve. And so, there's a chance that that might have a negative impact on us later in life. And there's also empathy, which obviously there's not a great way for us to assess empathy from a neuropsychological standpoint, but it does have an impact on how we engage with other people, our behaviors, what's socially acceptable. And so without having that social piece, we're missing something important. And who knows what that might look like for us later on.
Yeah, no, that makes sense. I'm thinking to myself during the COVID-19 epidemic, and then right afterward, going to a conference and talking to a colleague that was just made some kind of comment about, it's not that I'm more anxious than I'm used to, but, because I live alone during the pandemic, I almost feel like I've forgotten kind of the interpersonal skill sets. I'm kind of relearning them in a different way. And it's taxing, Obviously, that was a short-term thing, but you can imagine someone that's socially isolated for a long time. Let's say they retire and they live alone. You would have a very different level of sort of, input in the sense of kind of navigating what might not seem on the surface difficult, but navigating social interactions is actually very complex.
Yes, very much so. And we're also losing that even for those of us who are in the office in the same way that we were prior to the pandemic, just from our engagement with mobile devices and, our computers. We're all so connected to our phones. And think about the things that you're sacrificing when you choose to, doom scroll or do something on your phone rather than going out and trying to engage with other people, making connections that way. There's a lot that I feel like is lost. Now, don't get me wrong. I think there are other factors at play as to why that seems to be so exciting for us. There's something neurologically that's happening that engages us on our phones, but it's not the same as interacting with people in person.
Yeah. No, that's fascinating. Things that at the surface level, I wouldn't think of when I think of, cognition, cognitive decline, and older adulthood. But when you bring it up, you do think to yourself, wow, that actually is complex. Now, pivoting to just cultural influences and contextual influences to actually language itself. So you led work assembling an assessment battery for Farsi-speaking adults with suspected dementia. And my interpretation, you found very few measures had appropriate norms. What does a clinician do when a patient needs an answer now, and you literally don't have the right tools because of something like language?
Now, I'm fortunate to live here in Houston, which is a diverse community of individuals. And so I see a lot of people from different sociocultural backgrounds. And sometimes English is not their first language. It might not even be their second or third language. And so I'm faced with the task of trying to figure out, well, how do I assess this individual who's coming to me? They're referred from a provider, or maybe they're coming in as a self-referral with their own concerns. How can I give them a fair assessment? And so, unfortunately, the development of neuropsychology across the world looks very different. And also the tools that we as neuropsychologists here in the U.S., which is English-speaking, are different from those in other countries. So there might be well-validated and norm tools, but I don't speak that language, and so that's not going to be useful to me or the patient at this point in time. So, my colleagues and I were trying to come up with some commonly encountered languages that we face here in our clinic, and trying to figure out, well, what roadmap can we provide for others who are doing this kind of work or who want to be involved in doing this kind of work? And so, part of that paper was finding out that there's not a whole lot that we can do. And this is where clinical judgment and intuition has a big part. And so, again, I'm relying on my favorite tool, which I will argue with anyone about this, but it's my clinical interview. And it's extremely helpful to talk with a loved one who can provide an additional perspective beyond the patient in case, there's some limited insight or denial happening. But I want to know what brought them to the attention of their physician or what's concerning them. And then I want to know how their daily life has changed. Like, what are they still able to do and what are they no longer able to do as well or as efficiently? What kind of support are they getting from family that they didn't need before? And I'm using that to help guide my clinical decisions. And then, of course, I have my tests, which specifically for our Persian speakers, there are a handful of tests, but then we have other languages where there are no validated or norm tests for us to use at all. So while this is not a perfect guide, we do try to find measures where we can hope to limit, not eliminate, because that's unfortunately not possible, but limit the role of language on that particular test. So we're using things that have less of a component there, but we're also working with cultural interpreters or our cultural brokers. We think of them as our interpreters, certified medical interpreters for that language. And we hope that we can find individuals who've been doing this work for a while. Now, most of the interpreters we work with, they have not done neuropsychological assessment before. So they're getting a crash course in it when they meet with us. And that's usually right before they interact with the patient. And so we're trying to let them know what information we're requiring of them. And, it's a communal process in that way, because we want to make sure that the interpreter feels comfortable doing something that maybe they have no exposure to, but also that we're getting the most valid estimate of this person's abilities. But of course, the big point I want to hit home is that when we're documenting these findings, making it clear that there were limitations in the assessment. And for example, the selection of tests, the availability of norms for this specific person, because who is their peer reference group in this situation? And then the use of an interpreter, because we don't want to claim to not have had some sort of third-party influence happening here. And then as best as we can, we're using our clinical intuition to guide a diagnosis if one is warranted.
Makes sense. So it seems like such an important kind of area to, be able to be familiar with as a clinical neuropsychologist, especially living in a city like Houston or New York City, where I'm sure this is going to come up quite a bit. When you talk about interpreters, does the interpreter typically that you when you utilize them, are they kind of summing up what the individual is saying, or are we really talking about the level of sentence to sentence? And I'm asking this for a particular reason, but I'm just curious what that looks like in practice.
So we are looking at a very granular level, sentence to sentence, because I don't want there to be any influence of somebody else's interpretation. And so unfortunately, that's one of the pitfalls of working with an interpreter. Sometimes some people tend to want to provide just an overall level of what the person said during the interview. And I try to emphasize to them, I don't want that. I want to know exactly what they said. Obviously, in English, for my own understanding. But I don't want there to be any level of interpretation. But this is something we have to deal with even for primary English speakers, is that, they might say something and maybe because of the progression of their disease, they might have family who tries to clarify what they think they meant. And, that's something we have to deal with even for these individuals.
Sure.
But when it comes to an interpreter, we try to emphasize that when we're going over what our expectations are of them and what they can expect from us. And then we do try to manage that in the moment in real time as well.
That makes sense.
So especially when we notice it's like, they said a lot more than you just communicated to me.
Yeah.
Would you mind just letting me know everything that they've said? And then we try to document that as best as we can. When it comes to the actual test administration, there we've already emphasized to them, we want you to write down or tell us, document in some way exactly what was said. Because again, a lot can be lost in translation. And so we want to make sure that we're gathering the entirety, the scope of how the patient's answering, how they're processing the information. And then again, this is where clinical judgment comes in.
Yeah. And the reason why I asked that wasn't just to get into sort of process, although I think getting a picture of what this looks like is really helpful probably for a lot of people. But also, I'm curious if the culture in which the interpreter comes from, right? If they're from the culture that is associated with this language, right? If that actually is going to have influences in the same way where if I administer a lot of times a standardized depression scale in English and if we just switched to Spanish, you can do that now, with Google, but even with back translation and stuff, depending on cultural nuances, sometimes literally like the meaning is different. But what I'm hearing here is that guarding against that with sentence to sentence level is really one way to not let that seep in. And because of that, probably concerns that the kind of background of the interpreter doesn't have to be the same as the patient, correct? Like if I knew Farsi as someone that is white without any background, anything besides the language, I could still help to a certain degree.
You could still help to a certain degree, but obviously the preference is that someone's from a similar cultural background. Now, of course, we're limited by the interpreters available to us. There have been times where we couldn't find anyone who spoke that person's language, and so that hampered us. And there have been times where people are also maybe not U.S.-based originally, and they come from a different background than the patient, but maybe there are some similarities. But we also need to be aware of the nuances and the differences there as well. And sometimes that can create conflict in a different way. But we do our best to try to use our interpreters as cultural brokers as well in terms of understanding customs. Now, granted, as neuropsychologists, when we know a patient's coming in who's from a different background, we do our best in our clinic to try to familiarize ourselves with these different cultural backgrounds and norms, making sure that they feel welcomed and they feel comfortable in the room, doing an assessment they've probably never been asked to do, and to discuss topics that might be taboo or stigmatized in their culture. But beyond that, we're also, we also feedback from our interpreters about things that we might not have picked up on. So behavioral observations or, nuances in social structure. For example, if they notice that someone might be reticent to talk about certain things, or if they notice that there's a particular word on our test and it's like, we wouldn't say that in our language. That doesn't really have general conception that people can use. So these are all things that we document and we try to improve it for the next go around. It's not a perfect method, but it's the best that we have right now, knowing that we are trying to maintain a fair assessment the best way we can for this person.
Yeah, no, that makes sense. It also makes me think broadly in field of clinical neuropsychology, psychology more broadly. The importance of diverse cohorts coming into training. That diversity will then hopefully over time, and I think it would, kind of influence the way we're thinking about testing and the way we're thinking about these nuances, not from sort of an outsider assessed culture, but part of one's culture. Obviously, there's a lot of complexities of that, even just considering the demographics of the U.S. aren't going to represent the demographics of the world and such, where someone from Houston that speaks Farsi is going to be a common applicant, for example, to a neuropsych program. So I want to kind of pivot now to something that I kind of find really fascinating and exciting about your work in the clinic. And that has to do with going into surgery with a patient. So you do what's called language mapping during brain tumor surgery, and you actually go into the operating room. What are you doing in there? What is that all about?
I love talking about this aspect of my work because it is in some ways so different to the other things that I do, and it's really rewarding. So usually if a patient is referred to me from neurosurgery, it's because they have a brain tumor. And that brain tumor might be in an eloquent area of the brain, so an area that's important for language and communication. And so my goal is multifold. So first, I'm doing a preoperative assessment, and that might involve a full neuropsychological evaluation in addition to preparing them for some of the tasks that we'll be doing when we're in the operating room. I'm also assessing the patient's readiness and willingness to undergo an awake procedure, which I know their surgical team has already done that as well, but I'm coming at it from a different perspective with my background knowledge in clinical psychology and, the anxiety that might be building for that person who has never heard of such a procedure before, does not know what to expect, and is probably nervous and maybe stressed, perhaps terrified of what they're going to expect. So usually the pre-operative or baseline tasks that I'm doing with them that we're also going to do when they're in surgery are things that I want to make sure they know the answers to. So I need a selection of tests that I know that they can answer reliably.
Okay.
And that's part of how I ease some of that anxiety. It was like, this part, if you don't know the answer, don't worry about it. I'm going to throw it out. You won't hear it again, because I want to make sure that when we're in the operating room, I am confident that you know the responses to these things, because if you don't, that indicates to me and to your neurosurgical team that the area that they're electrically stimulating is an important area for language and communication, and we want to try to preserve that as much as possible. So the goal of an intraoperative language mapping procedure is it's a highly specialized, and it occurs during an awake craniotomy, which is, where they operate on the brain. And the goal is to make sure that we can have a maximally safe resection, or remove as much of the tumor as possible without causing any functional deficits. Because while prolonging life is a really great outcome, we also need to be aware of preserving quality of life. And if someone loses the ability to communicate, you can imagine what a big impact that can have on them. So when we're in the operating room, the person's usually there under anesthesia initially, and they remove the skull, expose the brain, and then I am interacting with the patient and the surgical team after they've woken up.
So when they go in, they're under general anesthesia where they're asleep, essentially.
Yes.
Okay. But then what I'm hearing is they wake up and their brain's exposed. Am I correct?
Yeah.
Take me there. And how are we able to do this and not hurt the patient? Can you tell me about sort of that as well? Like, what is all this looking like?
Sure. Now, there's no pain that's expected from, a brain surgery like that. But of course, people can feel discomfort. We're doing a number of different things. Some they're experiencing electrical stimulation. They're in a cold room. They're on a table and told not to move. So there are a lot of things that can make them uncomfortable. We do our best to make them comfortable. We try to make sure that we maintain alertness. So the anesthesiologist is in the room for the entire procedure. There's also the neurosurgeon and his or her team. And then there's the neurophysiologist who's making sure that there's no seizure activity, so that way they can try to mitigate that should it happen during the procedure. And then there is the neuropsychologist. My goal is to communicate with the neurosurgeon when I notice any errors. So, for example, if the patient stops talking or they stutter or they're making errors, that's a sign that that area that they're stimulating is important, and we need to preserve as much of that as possible. I'm also trying to manage the patient's feelings in the moment and making sure that they feel comfortable. And sometimes that involves me taking on a slightly different role where I'm notifying the team. It's like, well, this person's saying they're feeling really dehydrated.
Sure.
And it's making it difficult for them to respond to me in real time. Or, they're feeling discomfort in some way that is enough to distract them from our goal right now. And so, that takes on an equally important aspect, because I want to make sure that I have their full attention. And then we are testing things like naming ability. So I might show them a picture. I want them to tell me what it is. I might ask them to repeat some phrases or sentences, make sure that they can do that. There might be some reading involved. And then, of course, there are different activities we might do based on the location of the tumor and, any preferences the neurosurgeon might have in terms of wanting to assess certain functionings.
Mm-hmm.
And then, my clinical expertise as a neuropsychologist and what I think will be important. And then I'm just in general keeping them talking to make sure their expressive language or the way that they communicate and are understood by others is still intact.
And what does the surgeon do? Obviously, the goal is to get rid of the tumor, but the surgeon's, as you're giving these tasks, the surgeon is doing what to the brain to make it so you're assessing at that moment whether this is going to have an impact or not. Because obviously, if they were just cutting it out, it'll be irreversible. So that's not that's not what's happening. So what are they doing to kind of shut off that part of the brain temporarily to even, for you to do this task? What's going on there?
So they're using a probe to electrically stimulate those different regions of the brain while I'm testing or interacting with the patient. Mm-hmm. And so they are mapping out the different areas while they're being assessed. So that way, when my portion is done, they can actually go in and resect. Then that part is permanent.
That part. Mm-hmm. So when they're giving the stimulation, is that turning temporarily off that region so if it is or isn't, doesn't matter? Is it turning it on, or am I kind of missing exactly the big picture of what's going on there?
I don't want to make it too simplistic, so it's a little bit more nuanced than that, but they are disrupting the neural activity in that region, and that is where if we're disrupting that neural activity while they're doing some sort of function like naming, we'll use naming for example, does that function remain preserved? Is it intact? Mm-hmm. Or have we disrupted it to a point that now we need to be careful, because it's not just that particular region, but it's also interconnections between different pathways that we have to worry about.
Mm-hmm. Yeah, no, that makes sense. And what a fascinating part of your job. Does every clinical neuropsychologist get that experience in training, or is that something that many neuropsychologists would never be a part of, and it's sort of a specialized skill that you've honed in on, just for people that are sort of interested in the field broadly?
I'm very fortunate that I get to do this in my work, but it is not something that every neuropsychologist does professionally or that they've even been trained in. And that's in large part because of access to these training opportunities. So if you're in a larger academic medical environment where there's a lot of interdisciplinary work going on, this might be a possible area of training for you, but there are many programs where people don't have the opportunity to do that. And of course, depending on the setting that you're working in, this isn't something that would even be expected of you to know. So for example, if you are not affiliated with a hospital or academic medical center, this might not be a referral question for you. So if you're in private practice, for example, or if you happen to work with certain populations exclusively, you wouldn't be expected to do this. This, for me, came about in my training as I became more advanced, and I had the opportunity to work with supervisors who were already doing this work. And then when a colleague left, I took over from her, and that opened up an avenue for me that I hadn't considered.
Gotcha.
And that I was initially hesitant about, but I've grown to love, and I hope I continue to have this opportunity.
That's fascinating. These surgeries, from my understanding, can be quite long. Am I correct?
They can. And so our neurosurgeons are impressive. They're there with the patient for hours. And so the goal is not to have them awake for too long, obviously, because you can imagine how jarring it might be for some people to wake up from anesthesia, even when we prep them in advance, and to be participating in that, and then just increase their comfort level, obviously, to know that they'll be able to go back to sleep, be put back under anesthesia while the rest of the procedure is happening. There are also lots of sounds in the surgery room that I don't think everyone wants to hear. Imagine being at a dentist's office. We don't really want to hear those sounds.
Sure. No, that makes sense. But I can also see how you talked about, every clinical neuropsychologist, trained in different aspects of clinical psychology. Just building that rapport in such an amazingly sensitive aspect of one's life. I mean, I would be glad someone was trained as you are in just those relational components, right? Because it just seems such like a a very unique experience in the person's life that you're a part of, right? So I can definitely see those sort of soft skills being so important for the profession. Zooming out to a lot of what you do was, we talked about evaluations, right? And a lot of it has to do with assessing, cognitive decline. A lot of listeners from a practical standpoint are going to want to know, what are the signs that should prompt someone to possibly get a neuropsych evaluation? And here I'm talking in terms of an older adult. I realize that, we can always be talking about, signs for learning in childhood for, ADHD and such. We're talking about older adult. Maybe someone is noticing they're 70 years old. Oh, I'm forgetting things more. Or possibly a family member, that's probably the most likely, are noticing some things. What are the things that actually should prompt someone to seek evaluation versus that's probably not something to worry about?
Well, so older adulthood itself presents an increased risk for cognitive issues, and these might be related to a neurodegenerative process that's going on. So ideally, I would love it if everyone had access to obtain a baseline neuropsychological evaluation before the onset of cognitive difficulties.
Yeah.
But in our current health system, that's not possible or feasible right now. So some of the things that I would encourage people to reach out to a provider for a neuropsychological referral for include persistent memory changes. And that's not saying like I met somebody at church last week and I couldn't remember their name. It was the first time I met them and I struggled with it. But if that happens on a continual basis, or it even progresses to, well, now I can't remember people that I'm actually quite familiar with, and, or I'm struggling to come up with their names. We all have blips in our memory. So, for example, myself today, I was leaving the house, couldn't remember the security code. And, I don't panic at things like that, right? Because it was like, I know the code. It's just, I'm distracted at the moment. I'm trying to make sure I grab my keys, grab my water bottle. And so blips like that are fine. Now, if you're noticing that they're happening more, they're creating more serious problems. So now you're forgetting to take your medications, or you're having trouble remembering how to get to a familiar location when you're driving. Or maybe you're not as attentive and aware as you need to be while you're on the highway. Perhaps you got into an accident or you've had some close calls. Or maybe you've made some financial errors, either in monitoring your accounts, because I know everything's automated nowadays, or you've maybe put yourself at risk or made yourself vulnerable to scams. Maybe you picked up the phone and provided information to someone that you shouldn't. There's a change in judgment there that you didn't have an issue with before. For family members, they might notice that, mom or dad doesn't really seem to really engage in conversations in the same way. They don't really seem to know what's going on. Or maybe, patient or the family have noticed that they're making more word finding errors, or that they're just blanking on words altogether. And sometimes people can compensate for that, substitute words. Sometimes they can't. Other reasons why someone might come in is if they've had an event that we would expect to impact their neurological health, like a stroke or a mini stroke, sometimes called a TIA or transient ischemic attack. Or maybe they've had a head injury and perhaps they were told that that led to some bleeding on the brain, like a subdural hematoma or something along those lines. Or chronic illness, especially in older adulthood. And we know that even if it's not intended to impact the central nervous system, which includes the brain and the spinal cord, it might have impacted other things that have an indirect effect on that. So the medications that they're taking. So if someone taking certain medications that have a known impact on the central nervous system, or they're taking so many medications that now their thinking is cloudy or they're experiencing some brain fog. It might be an acute illness, like an episode of delirium, where their attention and alertness are drastically different than what it used to be, and it seems to be fluctuating in nature. If someone starts experiencing what we call late onset psychosis. So they're seeing things that aren't there, or hearing things that aren't there, or they might be misremembering things or imagining things that never happened. Those are all good reasons to seek out a neuropsychological evaluation.
Yeah, that makes sense. And when we talk about all of these kind of constructs, we're talking about assessing for some type of deficit or decline. If someone finds out, for example, that they have whatever it is, are there things they can actually do with that information in a positive way that would make it so, it would motivate one to, get these kind of diagnoses early because their lives could improve? Because I think a lot of people, when they hear, oh, I'm going to go get this assessment of whether in older to where I have dementia. Well, if I find out I have that, is there anything going to change, or now do I just know I have something I was worried about? Are there things that one can do once they know what is going on to improve?
Mm-hmm. So in our evaluations, we talk about cognitive strengths and weaknesses, and we provide recommendations for the patient, and if family is involved, for them as well, about things that they can do. Obviously, this is largely dependent on the diagnosis that we're giving. Sometimes I see people and I'm saying, good news, everything looks fine. There are no areas of impairment that we could identify, but here are some ways that you can be proactive about your brain health. And, that might be related to sleep health. If someone's got the potential for sleep apnea and they are showing signs that might be a factor, having them get that evaluated and then treated. It could be related to exercise, which is we have the most robust evidence for how exercise can promote brain health. And so encouraging them to initiate an exercise regimen as long as, there's a physician clearance on that, and, using our motivational interviewing skills to just get them started thinking about ways that they can incorporate that, because it's not the easiest thing to be motivated for. Nutrition, things that already increase their risk for things that might impact their brain health, like, if they are at high risk for stroke or they're at high risk for heart attacks, making sure that they're, keeping with their medical regimen, following up with their physicians about maintaining the routine that they're expected to be on, following up with those things. And then also, if they are not maybe in that normal range, but maybe we do see some weaknesses, not quite at the dementia stage, but maybe they meet criteria for mild cognitive impairment. We might recommend those same strategies, but in addition, they might be eligible for cognitive rehabilitation. And so that can help them learn to compensate or find other strategies or processes for dealing with some of the weaknesses that we see on testing, and with the goal of maybe mitigating progression to something more serious like a dementia.
That makes sense.
And then, of course, for our individuals who we're diagnosing with a dementia, let's say Alzheimer's disease, we want to make sure that they're connected with follow-up neurological care, so making sure they have a dedicated neurologist who specializes in working with individuals with memory disorders and who is kept aware and educated about the different treatments for it. So, in the past few years, we've had a lot of major developments in the treatment of Alzheimer's disease. And so making sure that, they're connected with someone who can talk with them about their options for that if they decide to pursue it. And then, depending on the stage of their dementia, some resources for the caregiver about things that they can do, because we don't have a lot of control at that point, but how can we improve quality of life for both the patient and the caregiver? And Chris, you've done a lot of work in that realm in terms of caregiver burden and stress. So I know you're well versed on that, but making sure that they know that there's help out there, there's support available to them. And then, some of the other things that we talk about is intellectual stimulation, social engagement, all of these things that people might not have prioritized.
Yeah, though that all makes sense. You use the word brain health, and I hear that a lot more, even the last 2 years than ever that term was used before. And I know it coincides somewhat with work to show there is an aspect of brain health that we can think of as preventative in the same way we've thought about cardiovascular disease and cancer. There's things we can do to improve our odds, right? So what would you just advise, anyone to do? Let's say they're in midlife or younger. What are the things that you would advise people to do to protect their brain health?
If I could only give one recommendation for someone in midlife, I would say start your workout regimen now.
Got it.
There's a lot of research in the past and coming out now that shows that midlife physical activity has great benefits for brain health in older adulthood. And so, the requirements for physical activity, it feels like they're always changing. Do I need 10,000 steps or do I need 12,000? Or, am I supposed to do 150 minutes of cardio, or what exactly is expected of me? I would say, while all of that is really helpful information, just getting into a routine that you can maintain even when you have a busy lifestyle otherwise. And it shouldn't just be cardio or aerobic exercise. You should also be incorporating strength training.
Even for brain health. Okay.
Yes. So, lift those weights. And I'm not expecting you to complete an Ironman challenge or anything like that, but just get your body moving. And this can be achieved in many ways. Some people don't like the idea of running. Some of us only run when we're being chased. But it could be water aerobics, or, say somebody likes swimming, or let's say they enjoy doing some sort of technology-assisted aerobic exercise, like those Wii games, or I've seen other things where people have like YouTube platforms connected to things. As long as you're getting your heart pumping, the big thing is that if it's good for your heart, it's great for your brain. So keeping that in mind. And of course, some of the other things we've talked about, we don't tend to prioritize sleep a lot in our culture. Sleep is incredibly important. And so making sure that you're getting a good night's sleep, you are eliminating distractions that might be a barrier to that, and that if you are having any issues with sleep, you get those evaluated early. I have had many discussions with people in, midlife, maybe trending into the older adulthood stage, about the importance of treating their sleep apnea. And I know that the devices that you're asked to use are not always the most comfortable. Sometimes it's a matter of, just an adjustment period, and sometimes it's maybe a little bit more than that. But that can have such a big impact on brain health. Beyond that, nutrition. We are, and I'm pretty sure I've stolen this from someone, and so whoever it is, I'm going to give credit to them. But we are very well fed in the United States, but we're not necessarily well nourished. So making sure you're getting in all your nutrients and vitamins, and that does not mean going to GNC and like clearing off the shelves, but it does mean making sure that you're getting in fruits and vegetables. And there's some research from certain diets like the Mediterranean diet or the MIND diet about these lifestyle practices being supportive of brain health to a degree. So making sure you're monitoring those lifestyle activities, and that will not just be good for brain health, but for physical health as well. So it's a twofer. And then of course, as we said, intellectual stimulation, whether you decide to learn a second language or pick up chess or mahjong, or you decide to take a class doing something that you love or that you've always wanted to, or listening to a podcast.
Yeah. Right.
Yes, exactly. As long as you are finding something that is intellectually stimulating that can confer health benefits for you. And then with the social engagement piece that we're talking about, spending time, a little bit more time away from your phone, trying to get out, meet people, make connections. And that's important not just for brain health, but in speaking with some of my older patients, it's really hard to make friends as you get older, especially when you think of the things that commonly occur in older adulthood. People moving away, people maybe changing in terms of cognitive abilities, and so maybe you guys aren't socializing in the same way, or unfortunately people passing away. Build your communities now.
Yeah, you sort of build all that resilience beforehand. Well, thank you so much. Really appreciate you coming today. I think all of our listeners would agree that they learned something new, and hopefully it also motivates people to, take charge of their brain health early, because it sounds like there's a lot of hope in that regard. With that, just thank you so much for coming.
Thank you so much for having me, Chris, and I'm looking forward to more episodes of your podcast. I think the work you're doing is excellent.